Hello friends, today we will start a series of lecture on stomach and duodenum, and in that we will be covering initially the anatomy and physiology of stomach, followed by various pathologies which can occur in stomach or in duodenum, particularly the peptic ulcer, the bleeding, upper GI bleeding, malignancy, which are very important conditions of stomach and duodenum. So let us first, before we go on to those pathologies, let us first understand the anatomy and physiology of the stomach. If you look at this picture shows that various parts of stomach. You must be aware that the terminal 3 to 4 centimeter of the esophagus is intra-abdominal. As it comes out of the esophageal hiatus of the diaphragm, it runs about a course of 3 to 4 centimeter inside the abdominal cavity, then it joins the stomach. So that junction is called gastroesophageal junction. You can see in this picture, it shows that the gastroesophageal junction. The part of the stomach next to that is called cardia or cardiac part of the stomach. The part of the stomach which lies above that, actually some part of the stomach is projecting even above the gastroesophageal junction mainly onto the left side. This is called fundus, and this part is highly distensible. So it contains food fluid as well as the fundal gas, because as the gas rises, whatever gas is collected in the stomach, it generally rises and collects in the fundus. Rest of the main body of the stomach is called body or corpus, and as it goes below and turns towards the right side and joins the duodenum, that junction area with the duodenum is called pylorus. There is a slight narrowing that is called pyloric channel, and the area of the stomach next to that is called antrum. Rest of the part between the fundus and antrum is called body. You can see that stomach has got two curvatures, one on the medial side and one onto the outer side. The curvature which is small and running medially is called lesser curvature, and the one which is longer and runs onto the outer side or the lateral side of the stomach is called greater curvature. So this is the basic anatomy. Now let us understand what are the layers of this stomach. Stomach has got multi layers. It is relatively thick walled as compared to the other parts of the gastrointestinal tract. It has got a good and thick serosa. Outermost layer is serosa, and has got muscularis propria underneath that. The muscle layer is of longitudinal and circular. Between the muscle and the innermost part, which is this mucosa, there is a layer, well defined layer, that is called submucosa or submucous coat. The mucous membrane has got a well-defined laminar membrane underneath that. If you look at the stomach from inside, you will find that you can see, look at it during endoscopy or during surgery, you will find that the innermost mucosal layer is thrown into multiple folds. These folds are called, and these folds are generally longitudinal, running from above downwards towards the pylorus, and these folds are called rugae. And when the stomach is in normal shape or contracted, these rugae are very prominent, but as the stomach gets distended for any reason, maybe with food or maybe with gas, or during endoscopy when you fill gas into air into that to look at it, these rugae flatten out and disappear. The innermost layer, the mucosa, mucous membrane or mucosa, is covered with a thick layer of mucus, which is very protective in nature. And out of all these layers which I described, the serosa, muscularis propria, mucosa and submucosa, the most strongest layer is the submucosa, and it is the infiltration of this submucosa or not infiltration of this submucosa is what causes the tumor or a malignancy to spread. So we should remember that out of all these layers, the strongest layer is submucosa. Now coming to the blood supply and venous drainage, arterial supply and venous drainage of the stomach. Stomach is a very vascular organ. You know that it has got its own advantage because stomach has got multiple blood supply, and because of that, even if one or two arteries need to be cut or ligated during surgery to mobilize the stomach can survive on rest of the blood supply. And the other advantage of this good blood supply is that any surgery you do on the stomach, the healing is very good because good blood supply, so good healing. The problem with this highly vascular supply of the stomach is that since it has got good blood supply and good venous drainage, any tumor spreads fast because they generally spread by blood, so it spreads fast. And secondly, if there is a ulcer or some bleeding point in the stomach, it bleeds massively because blood supply is very good. So if there is a bleeding ulcer in the stomach, or if there is a some lesion in the stomach which is bleeding, it bleeds a lot because very good blood supply. So there are advantages and disadvantages of having this good blood supply. Mainly there are advantages. Firstly, I will name all the blood arteries of this arteries which supply the stomach, and then we will see those arteries in a picture, because by looking at the picture you will understand the best. The arteries are the right gastric artery, left gastric artery, right gastroepiploic, left gastroepiploic, and multiple short gastric arteries, 5 to 7 in number. So to repeat that, right gastric artery, left gastric artery, right gastroepiploic artery, left gastric epiploic artery. Epiploic means stands for omentum. So right gastroepiploic means which supplies the stomach as well as the omentum. So right gastroepiploic, left gastroepiploic, and multiple short gastrics which are generally 5 to 7 in number. So now look at this picture. Looking at this picture, you will understand. You can see that aorta is just on the medial side of the stomach and running posterior to the stomach. So from the aorta, the celiac axis arises, which is a short, thick blood vessel, and it immediately gives three branches. So the first branch is left gastric artery, and it goes slightly above and then runs along the lesser curvature of the stomach. You can see in this picture, and this left gastric artery is the biggest or thickest artery supplying the stomach. You can say biggest or thickest or largest. So it is one of the largest blood vessels supplying the stomach. The other blood vessel, again, which takes origin at the celiac plexus next to the origin of the left gastric artery, is the hepatic artery. As the hepatic artery takes origin, goes slightly downwards and to the right, then it gives a branch called the right gastric artery. That right gastric artery runs towards the lateral side, towards the left side, and runs along the curvature of the lesser curvature. You can see it in this picture. It is taking origin from the hepatic artery, and then it is turning towards the lesser curvature. So there is a good anastomosis or good collaterals run between the left gastric artery and the right gastric artery. So these are the two main arteries. Now this hepatic artery goes and supplies the liver. It goes into the free border of the lesser omentum, then divides into right hepatic artery and left hepatic artery. But before it curves up towards the liver, at that turning it gives rise to one big branch that is called gastroduodenal artery. Gastroduodenal means it supplies both the stomach as well as duodenum. Not only duodenum, actually as it goes behind the duodenum, then it goes and supplies the pancreas also. It gives a branch called superior pancreaticoduodenal. And as it goes behind the duodenum, it goes further as superior pancreaticoduodenal. At that point, a branch of it turns along the greater curvature. That is called the right gastroepiploic artery. I told you, two epiploic artery, right and left. So this branch from the, you can see it as the gastroduodenal artery, goes behind the duodenum or the retroduodenal course, and then it goes and supplies the head of the pancreas, that is pancreaticoduodenal. It supplies the head of the pancreas as well as the adjoining part of the duodenum. You can see in this superior pancreaticoduodenal artery. But at that point, it also is taking a turn towards the greater curvature and runs along the greater curvature and joins the left gastroepiploic. You can see the left gastroepiploic is coming from the splenic artery. So this both left gastroepiploic and the right gastroepiploic, they join and they combine, they supply the greater curvature of the stomach as well as the greater omentum. And same from the splenic artery, there are multiple, about 5 to 7 branches. You can see those small branches taking origin from the splenic artery. They supply the upper part of the greater curvature of the stomach and the adjoining part of the spleen. These are called short gastric artery. What is the importance of this gastroepiploic? It is a very important artery, though not a very thick artery, but it is a very important artery. What is the importance? In those operations where you have to mobilize the stomach and make a gastric tube to replace the esophagus, you have to make a stomach into a thinner tube, and then you have to take it through the hiatus into the neck. And I told you, for the esophageal carcinoma, sometimes you use this gastric tube and anastomose hit here in the neck with the cervical esophagus. So when you make the gastric tube, for mobilization of the stomach so high, you have to cut all the major blood supply of the stomach, particularly the left gastric artery, because left gastric artery is short. If until unless you cut that, you cannot pull the stomach up. Similarly, you have to cut the right gastric artery. So whole of the stomach has got only one blood vessel left, that is the gastroepiploic artery, and this single artery is good enough to supply the whole stomach when you do the mobilization. And you have to protect this artery, and you can take the stomach up to the neck and do the anastomosis. The stomach will be supplied by only one artery, that is this gastroepiploic artery. So I told you, it's not a very thick artery, but very, very important artery, and can supply the stomach when it needs it during mobilization. Venous drainage of the stomach is into the portal venous system. You know, we have discussed that while discussing the portal hypertension. So the blood supply goes to the portal vein. The most important part of this venous drainage is the left gastric vein, anterior branch of the left gastric vein, or which is also called as coronary vein. I told you, during portal hypertension or variceal bleed in portal hypertension, is this coronary vein is the one which causes the maximum bleed during variceal bleed in the gastroesophageal junction in portal hypertension. So you should know about this, because this is the vessel which is the cause of that bleeding, and if you have to do an open surgery and do a devascularization, you must take care of this vein, because this is the one which causes maximum bleeding. Now let us go to the nerve supply or innervation of the stomach. Stomach, like good blood supply, has got good nerve supply also, and gets nerve supply parasympathetic through vagus and sympathetic through the celiac plexus. The vagus, you know, comes from the brain. The vagus nucleus is lying in the fourth ventricle of the brain, in the floor of the fourth ventricle, and then it comes into the neck. Here in the neck it is lying in the carotid sheath. Along with the carotid artery and the internal jugular vein, the vagus is also lying. As it comes into the thorax, it lies on the surface of the esophagus, but there it doesn't remain a single trunk, it generally divides into multiple thin branches. But as it comes back into the abdomen from the surface of the esophagus, it again regroups into two major vagus, left vagus and right vagus, or also called anterior vagus and posterior vagus. You remember stomach, when it rotates like, this is my stomach, it rotates like this. So left becomes anterior and the right becomes posterior. It is in the embryonic condition, it is like this, and then it rotates like this. So what was initially left becomes anterior, and what was initially right becomes posterior. So similarly, the left vagus is anterior and the right vagus is posterior. When you look at the vagus nerve during surgery, you will find right vagus nerve very well defined, or generally a single trunk, quite a thick trunk. You can feel it easily. It is lying just behind the upper part of the stomach. Left vagus or the anterior vagus is generally not that thick and not a single trunk. Most of the time you will find left vagus into 2-3 multiple trunks, and it is really difficult to locate all the branches, but if you look carefully you can find that. There are two important parts of the vagus nerve, or two important branches of the vagus nerve which have been named. One is called criminal nerve of Grassi and the other is called anterior branch of the anterior nerve of Letarget. So what are these two nerves and what is their importance? Criminal nerve of Grassi is the first branch of the right or the posterior vagus. As I said, right vagus is posterior, so as it gives branches to the stomach, it gives a branch called criminal nerve of Grassi. Why it is called criminal? Because if you don't ligate this or don't take care of this branch during surgery, then it is criminal. Why it is criminal? Because this is the nerve which keeps supplying the stomach and is the cause of recurrence of the ulcer. So when you are doing a surgery for ulcer and you are doing a vagotomy, if you don't take care of this branch, then there will be recurrence of the ulcer. That's why it's called criminal nerve of Grassi. And what is the anterior nerve of Letarget? Anterior nerve of Letarget is branch of the left vagus, because anteriorly is the left vagus, and as it reaches the antrum, then it gives this branch, and if you spare this branch during the highly selective vagotomy, which is done for the ulcer surgery of the stomach surgery for the peptic ulcer, you leave this branch, anterior nerve of Letarget, because then it keeps supplying the antrum and the milling action of the stomach is maintained, because rest of the anterior branch of the stomach supplies the acid producing area, whereas this anterior nerve of Letarget is supplying the antrum, which has got the main milling action, the breaking of the food particles. So you leave this anterior branch of Letarget. So these two nerves you remember: anterior branch of Letarget, branch from the left vagus, and the criminal nerve of Grassi, branch of the right vagus. The gastric, the stomach has got a pacemaker from where the main motility or the contraction of the stomach starts. Where is this pacemaker? There is no special, like if you start looking for the pacemaker, you will probably not find it. But scientists who have been working on the stomach, they found it that it is located somewhere in the body of the stomach. I showed you the body in that initial picture, near the greater curvature. And this pacemaker is made of interstitial cells. Those have been named as interstitial cells of Kajal. So these interstitial cells of Kajal are critical for generation of the sequential contraction, which starts from this stomach as peristalsis and goes further down. So this is the one which starts the peristalsis from this in the stomach, and this pacemaker is located somewhere in the greater curvature in the body and is made of interstitial cells of Kajal. So that means for the anatomy of the stomach,